Good evening, everyone. Welcome to this evening's Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer at GoTo for Lung Cancer. Tonight, we're talking about small cell lung cancer. As you guys have heard me say in the past, small cell lung cancer historically hasn't got quite the attention that non-small cell lung cancer has. And so we're thrilled to be able to bring to you information on what's happening right now. And really, our objectives tonight are for you to know exactly that. What is happening right now in both limited stage and extensive stage lung cancer, and what's coming down the pike. Why do we have reasons to be hopeful? And tonight we have a very special guest, Dr. Carl Gay, who is assistant professor at the Department of Thoracic, Head and Neck Medical Oncology, Division of Cancer Medicine, University of Texas, MD Anderson Cancer Center. So he's coming out via the live stream all the way from Houston to talk to us tonight. And we couldn't be more thrilled to have him here. Thank you so much again for being here tonight. I think we're going to start out with some basics, particularly for some of the newbies that are here and may not know a lot about small cell lung cancer. So let's talk generally about what is the biggest difference between non-small cell and small cell.
I often say, including when I'm speaking to people that should know better, whether it's industry partners or what have you, that really the only thing that non-small cell and small cell share in common is that they arise from the lung. Biologically, they are quite distinct. Some of that information is in the name. Small cell lung cancer is indeed composed of very small cells when you look under a microscope, and it's aptly named in that regard. But it arises from a different cell of origin in the lung, so-called neuroendocrine cells, which are these rare cells whose, frankly, function is not entirely well understood, other than to know that they're rare and seemingly inconsequential, but can be extraordinarily consequential when they become malignant. And so, unlike non-small cell lung cancer, it tends to be very aggressive. Again, non-small cell lung cancer is plenty aggressive in its own right, but small cell lung cancer is truly in a different category. Metastasizes to a lot of the same sites, but otherwise follows a relatively dissimilar natural history, where the disease spreads very early in the process, and so it's unfortunately very rare to catch it early, and to catch it in a limited stage setting. And from there, the fact that it can respond to therapy is something that we've had in our pockets for many decades, but really haven't been able to capitalize on. And so unlike non-small cell lung cancer, the ability to durably control small cell lung cancer has also been a key distinction. And then I think the biggest thing in the last decade, 15 years that we've appreciated is that all of the pie pieces that compose the non-small cell lung cancer spectrum, EGFR, ALK, KRAS, all of these things, those don't really exist in small cell lung cancer. It's consistently due to the same pair of mutations. Those are mutations that at least our current therapies don't selectively target the way that non-small cell lung cancer therapies have evolved to do. And so again, it's from the lung, and so all the same doctors treat it, but for the most part, a very, very different disease.
Is it staged the same way?
The staging criteria that we use for non-small cell lung cancer, the so-called AJCC 8th edition, this is the TNM staging, that can be applied to small cell lung cancer, but it's often not practically applied to small cell lung cancer because it doesn't typically distinguish the way we treat the patients. And so typically we just decide whether a patient has limited stage or extensive stage disease. Extensive stage disease is relatively synonymous with stage 4 disease, with rare exception. And then everything else is clustered into limited stage disease because much of that, if not all of it, is treated similarly.
So before we start talking about treatments, I want to talk a little bit about the diagnostic process. You mentioned metastasis and that for all intents and purposes, if this cancer is going to metastasize, it will metastasize to similar places, if not the same, as non-small cell lung cancer. But one of the things that I think I want to talk a little bit about here is brain metastasis specific to small cell lung cancer.
The staging workup, to which you allude, is similar to what we see for non-small cell lung cancer. We try to get a PET scan or a CT, chest, abdomen, pelvis, and bone scan, and we try to get a brain MRI for all of our patients. And that's true for non-small cell. I think the distinction is that we're more likely to find metastases in small cell lung cancer. We're less likely to capture patients when they have disease localized to the lung or to the lung and the lymph nodes. And as you mentioned, brain metastases in particular are extremely common in small cell lung cancer. There are different estimates in the literature, but generally you'll see something ranging from 60% to 80% of all small cell lung cancer patients will at some point during their treatment course develop brain metastases. And so it's more likely than not that patients will at some point encounter this. And so if you don't see them at the outset, you have to remain very vigilant as you go. These are patients that get brain MRIs often every 3 months for the duration of their lives following their diagnosis, which is not typical of non-small cell.
Yeah, thank you. I think it's a really important piece of information for those diagnosed with small cell lung cancer to know and to have conversations with their healthcare providers about are these routine brain MRIs to check for brain metastases. So before we get into which treatment options might be appropriate for which stage, what are, at a high level, some of the treatment options that are available for small cell lung cancer?
For decades, chemotherapy has ruled small cell lung cancer for better or worse. This is, in the United States, for the most part, a combination of two classes of drugs, platinum and etoposide. And these are the backbone of essentially everything we do for newly diagnosed small cell patients, regardless of stage. And for many years was virtually the only thing that we could do for patients that had small cell lung cancer. There are other chemotherapies that are deployed perhaps in later line settings or for patients that may not be, for whatever reason, eligible or tolerant of some of those, but much less successfully when they're deployed. Recently, the treatment options have evolved in a beneficial way, and so we've seen the addition of immunotherapy, immune checkpoint inhibitors to our small cell lung cancer regimens, and we've also seen the just more recently the inclusion of a relatively novel class of agents called T-cell engagers, or bispecific T-cell engager in this case. I think we can talk about later, and a really fascinating mechanism of action and something that brings a lot of optimism to the field. Still, chemotherapy is doing a lot of the heavy lifting in this disease, but finally we're finding ways to engage the immune system. And then something that's not quite ready for prime time in the sense that it's not approved yet in small cell lung cancer, but I think deserves some attention, which we'll probably give it later, are a unique class of chemotherapy delivery agents called antibody drug conjugates, or ADCs. And again, I think a really creative and novel way of treating cancers. Moving away from the chemotherapy that just kills anything that moves to something that feels a little bit more personalized, a little bit more specific in treating the tumor.
Thank you. And I think that one of the things that's interesting to note, and I'm curious if you have if there's a scientific explanation as to why, or at least a hypothesis. You mentioned chemotherapy historically being primary first-line treatment and even second-line. And the tendency in small cell, when that was the only option, was for it to respond really well in the first-line setting, but not necessarily as well in subsequent settings. Can you talk a little bit about that?
The natural history of small cell lung cancer was something that always fascinated me, because you have remarkable responses to these initial chemotherapy agents. Response rates in the 70% range, much better than what we see in other lung cancers to chemotherapy. The responses are rapid, often within days, and can be nearly complete, right? I mean, you can do a scan of these patients after 2 cycles, and there's no apparent evidence of disease. But unfortunately, we know it's coming back in almost every case. Chemotherapy has the ability to kill the majority of the cells and kill them quite handily, but there are some cells that persist. These cells that persist, unimaginatively termed persister cells, or drug-tolerant persister cells, have become a huge focus of interest in small cell lung cancer and elsewhere. These cells that somehow adopt a dormant state, are able to evade the initial insult of chemotherapy, and then when the coast is clear, able to come back and thrive. We understand part of what makes those cells tick, right? That they're not as prone to cell division. They're not as active as these other cells, so that makes them less vulnerable to chemotherapy. They seem to be very plastic, and when I use that term, I mean they can kind of adopt different fates. And so depending on what you're treating with, they can shift to a different fate that's less vulnerable to that, and they can also repopulate the tumor. Not going so far as to term them as stem cells or cancer stem cells, but kind of a similar notion. These are the difference between a really nice response that might last a few weeks and seemingly cure in patients. And so this last percent or 5% or whatever it is when you quantify it is a huge unmet need in small cell lung cancer, and trying to figure out therapies that are not only effective in the way chemotherapy is, but effective at eradicating these persister cells, I think is where the field is going in the next 3 to 5 years.
Yeah, which is really fantastic. Let's jump into limited stage. What are we doing now with people who present with limited stage lung cancer?
Limited stage small cell lung cancer is generally when the disease is confined to a single side of the chest. So the lung and the lymph nodes in the vicinity of that lung. So these are patients that we treat with curative intent. We don't successfully achieve that as much as we would like, but certainly our goal is a definitive and curative therapy. The primary treatment when you meet these patients remains a combination of chemotherapy and radiation that are done concurrently. That's at the same time. And we try to start both of them as early in that process as we can. And until recently, that was it. You'd finish chemoradiation, you'd get through 3 months of chemotherapy, several weeks of radiation along the way, and then you would stop and watch. Now we're almost a year into a new era, dating back to June of last year when we saw a presentation from the Adriatic study, which for the first time demonstrated that instead of stopping at the end of chemotherapy and radiation to add immunotherapy, an immune checkpoint inhibitor called durvalumab, for up to 2 years at that point, results in a dramatic increase in the life expectancy of these patients, as well as the duration of time they have before the cancer recurs. And so now it's concurrent chemoradiation followed by up to 2 years of immunotherapy.
Yeah, really great things coming out of that trial, and yet another great example of how immunotherapies are impacting how we treat lung cancer. Let me ask you this. Is it ever an option for surgery for these limited stage patients?
I'm so glad you asked that, because I think surgery is something we're too dismissive of in small cell lung cancer. Right now surgery is for a very selected population of patients with small cell lung cancer, generally confined to patients that have a single solitary lesion in their lung, usually a couple of centimeters at most in size, no lymph node involvement. Those patients might have surgery initially, or they might have what's called stereotactic radiation initially, and then that's followed with chemotherapy. I think as our therapies get better for small cell lung cancer, as we're able to control the disease we can't see, in addition to the disease we can see, I hope that we'll start to introduce more surgical options for patients. Patients like the notion of surgery. Patients like having the cancer out of them. And we are, I think, too restrictive in applying surgery to small cell lung cancer in a way that maybe limits our opportunities for cure for those patients with some early stage disease.
And what, in your opinion, is the reasoning for some of those restrictions or the thought processes around it?
Historically, it was simply the futility of the approach, that the cancer was going to come back anyway, and that surgery just delayed the time before the patient might get to chemotherapy. There are other variables. Small cell lung cancer patients are often, but not always, smokers, and so that can impair their candidacy for surgery. Right? You have to have healthy enough lungs to tolerate removal of a lobe or more of your lung. And they may have other comorbid illnesses that make surgery less viable. But I think realistically, it was just, if the cancer is going to come back anyway, why put patients through the surgery? But if things like immunotherapy can, as I said before, control some of that disease we can't see, right? We always say surgeons can only cut out what they can see, right? They can't tell if there's cancer cells in the bloodstream, and if there are, they can't do anything about those with a scalpel. So if we have a better way to control that, then controlling that primary tumor and the local lymph nodes surgically then becomes a more attractive option. And we've seen that in non-small cell lung cancer, right? As treatment has evolved there, we're offering surgery to more and more advanced patients now.
Yeah, and I was going to say, it would be interesting to see, and I hope to see it, studies done in these surgical candidates in the neoadjuvant and adjuvant setting, or the before surgery or the after surgery setting, because there are similar challenges in early stage non-small cell, to your point. They can only cut out what they can see.
Yeah, and I think neoadjuvant in particular, so neoadjuvant means treatment before surgery. And I think that in particular is attractive for small cell lung cancer because we have therapies that work exquisitely well at shrinking the tumor, controlling the disease. It just doesn't control it for long enough. But if you can shrink the tumor up, obliterate a lot of the disease, both the visible and invisible, microscopic disease, then you might take a patient that's not a surgical candidate up front and convert them into a surgical candidate within a 2 or 3 month span of neoadjuvant therapy. And so I'm aware of neoadjuvant ideas that are being kicked around. And so I think that's a way the field is going. And I'm really enthusiastic about seeing some attempts at this and bringing surgical opportunities to more patients.
I love that. Something to keep our eyes on in the future. So let's jump into extensive stage, where we know the majority of small cell lung cancer patients are being diagnosed. Let's talk a little bit about what's happening there.
As you say, somewhere between 2/3 and 3/4 of all the small cell lung cancer patients that we see are unfortunately extensive stage at diagnosis. And this means their cancer has spread beyond the lung and the local lymph nodes in a way that's visible on a PET scan or a CT scan. This might be brain metastases, bone metastases, liver metastases, adrenal metastases. These are the most common sites of distant metastasis. But essentially at this point, upfront strategies like radiation or even surgery are not feasible. You cannot encompass all of the disease in a radiation field that would be tolerable. And so you're left to focus on systemic therapies that are intravenously or less commonly orally delivered, that can circulate to every cell of the body and try to eradicate the cancer in multiple places in parallel. These patients are often quite symptomatic at the time of their diagnosis because the cancer spreads quickly and grows quickly. It's not uncommon to see patients that have pulmonary symptoms from their primary tumor, but also pain from their bone mets, neurologic symptoms from their brain mets, even symptoms from very large liver metastases or compromise in their liver function. And so this is really a race against time because patients are on the precipice of really bad outcomes if you don't intervene rapidly in extensive stage small cell lung cancer. It's one of the few, as a thoracic oncologist, one of the few real emergencies as we consider them that we face in managing patients both inside and outside the hospital.
So when we talk about some of these side effects, and I know we're going to get into talking a little bit about some of the exciting new things that are being used to treat extensive stage, but since you mentioned side effects, I think it's important to talk a little bit about palliative care and the importance of palliative care, in my very humble opinion, from the very beginning. But what are your thoughts on that?
I think that palliative care, whether it's a conversation about palliative care with the medical oncologist or also a referral to a palliative care expert, ideally, should be a part of essentially the first conversation you have with a patient with small cell lung cancer. If they don't already have symptoms like pain or like shortness of breath or anxiety related to their diagnosis, those symptoms are all but inevitable. And so I think establishing a multidisciplinary team to manage those symptoms, to give the patients options for folks to reach out to, even to just bounce ideas off of really early on, is something that's overlooked. We approach this disease so emergently that sometimes we forget about the way the patient feels, right? We see the patient, they come in through the ER, they're very symptomatic, their labs are very abnormal, the tumor is huge, and we say, you have to start on therapy today, and we'll sort out the rest of the details later. And sometimes that's necessary, but I think we often overlook making sure that the patient's symptoms from the disease and from the treatment that we're getting ready to deliver aggressively are managed in a longitudinal way.
I can see what you're saying and how the urgency behind starting treatment, some of this stuff can get lost, but I think that's why it's important that people diagnosed, their caregivers and their loved ones understand, A, that palliative care is not hospice care. It's really a supportive care to help through symptoms that to Dr. Gay's point, either the cancer are giving you or the treatments to treat the cancer are giving you. And a lot of relief can be found by engaging in palliative care, and it's never too late. Just because maybe palliative care wasn't introduced as an option at the beginning doesn't mean it can't be introduced at any time during your treatment.
Yeah, and I want to reiterate a point that you made there, which is that palliative care and hospice care are not synonymous. Palliative care should be a part of virtually every cancer patient's care for the duration of their care, certainly while they have disease and while they're on treatment, if not beyond. And I think it's important for patients to realize that that's, this is not a situation where you need to be a hero, right? If you're losing weight, I can't treat you as well. If you're so fatigued that you're not getting out of bed, or you're recurrently suffering pain that's preventing you from attending appointments and all of these things. These are all ways where the cancer treatment goes off the rails. And so making sure all of those symptoms that you require for your day-to-day, your activities of daily living, as we call them, make sure those symptoms are as well controlled as they can be so you can go about life as normally as possible. That leads to better success for me and for you.
Yeah, and I think it's important, and folks who are not new to this program have heard me say this before. I think quite often people in treatment are maybe a little anxious to talk with their healthcare providers about any side effects they may be having for fear of being taken off that treatment, when in reality, you need to talk about it as soon as it crops up so that we can then treat that and keep you on treatment, right? So some exciting new things in the last couple of years that have happened in treating lung cancer. We touched on this at the very beginning. Chemotherapy was really the option regardless of stage. And in the last couple of years, some really, really exciting therapies have been introduced. I don't know if you want to start. Well, I don't know where you want to start. I'm just going to let you start.
I think chronologically, the first big shakeup for small cell lung cancer in the extensive stage setting was the addition of immunotherapy, immune checkpoint inhibitors. And we had two successful trials back to back, the Empower 133 and Caspian trials, as they're known. And both of these showed similar outcomes, that if you add immunotherapy to the standard chemotherapy regimen that we've been using for decades in small cell lung cancer, that patients live longer, statistically significantly longer. Just to inject a little bit of sobering reality into the discussion, though, the benefit was modest, right? The number of patients, or the fraction of patients that benefit from immunotherapy in small cell seems to be narrower than in non-small cell lung cancer. So there was still a lot of room for improvement. Probably 10 to 15% of the patients that really experienced long, durable benefit from the addition of immunotherapy. The others were responding to the chemotherapy and then fairly rapidly failing once they got beyond the chemotherapy. And so after the initial wave of immunotherapies came to pass, we've seen a few drugs that were approved in the relapse setting. So for patients who failed that initial line of therapy, be it chemotherapy or chemotherapy plus immunotherapy. The first of those was a drug called lurbinectedin, which functions in ways similar to a chemotherapy. It has a similar effect on cancer cells, but I think patients often find the story of its creation somewhat interesting because it's sort of a naturally occurring molecule. It's derived from a marine organism called the sea squirt. It sounds like something from science fiction, right? That you would find, in this rare marine organism, an anti-cancer drug, and it's quite effective even in patients that have relapsed small cell lung cancer. And then more recently, the approval of a drug called tarlatamab. This is the first drug to get approved from the class of therapies I mentioned earlier called T-cell engagers, which are really, really fascinating. I think that has been a much more recent game changer. That's, we're less than a year from that approval now. And I think people are still trying to figure out where it fits into the treatment paradigm and dealing with some of the unique features of this tumor, both in terms of its effectiveness, which is distinct from anything we've had before, but also its toxicity profile, which is also quite distinct.
Yeah, so I do want to take a deep dive into the approval of tarlatamab, but I want to step back really quick to the immunotherapy space, again, for those who might be new to this programming, just to, in very simple terms, remind you that immunotherapies are intended to activate in one way or another your own immune system to identify the cancer and kill it. And I'm just saying that that's important because as we jump into this T cell therapy, I do want to talk a little bit about how it works and what makes it different from a chemotherapy or a radiation therapy or an immunotherapy.
Yeah, I think that's an important distinction to draw here, and I think will be a useful transition into the T cell engagers as you described. And so, both chemotherapy and radiation work by killing cells that are dividing. Right, those cells are vulnerable because they're constantly creating a new set of chromosomes. They're replicating their DNA, and there's some vulnerabilities that come along with that when one cell becomes two. You can kind of kick those cells when they're vulnerable. Immunotherapy works in quite a different way, and I think you described it in very accurate terms. It's the goal of immunotherapy is to try to force the immune system to reckon with an enemy that's been hiding in plain sight. Right? The tumor has been there. The immune system has failed. The immune system should have recognized that tumor in its earliest stages and eradicated it. Small cell lung cancer is unique by lung cancer standards, by solid tumor standards in general, at its ability to seemingly evade the immune system. And so when you take a biopsy of a small cell lung cancer patient, you don't see immune cells present in the biopsy more often than not. And so it's as if it has the ability to repel the immune system or eliminate it once it's there. And so immunotherapy in a fraction of patients will allow the immune system to realize that enemy has been hiding in plain sight, will activate it, as you say, and the immune system will go about attacking an enemy that looks abnormal, right? That should have been recognized as abnormal from the outset. It just doesn't work frequently enough in small cell lung cancer. And so more often than not, the tumor is still able to hide from the immune system or repel the immune system. And so we need more creative ways to force the issue.
Smarter ways.
Yeah.
Okay, now let's talk about BiTE therapy.
BiTE therapy or bispecific T cell engagers, you'll sometimes see them called just TCEs or for T cell engager. It's a very jargony term, but it's one of those development stories that even folks that don't have any background in cancer biology or biology, I think can appreciate the strategy. And basically, the way it works is you have two antibodies that are fused into one molecule. One of those antibodies is attracted to a feature of the cancer. The ones we're going to be talking about are attracted to a protein called delta-like-ligand 3, or DLL3, which is expressed in the vast majority of small cell lung cancers. It's expressed at the surface of the small cell lung cancers. So it's a protein that can kind of act as a beacon to theoretically tell the immune system it's in the right place. The other antibody that's fused here binds to your T cells. It binds to your immune cells. And those are the cells that have been either ignoring the tumor or repelled by the tumor. And it literally forces an interaction between the two, right? It's like taking two kids that are pouting and forcing them to face one another and apologize and make up, right? And so it's, two things that have been ignoring each other that no longer have the option to ignore one another. And so, when you infuse theoretically this bispecific antibody into patients, suddenly they should get a rush of T cells that are being forced, for lack of a better term, into the tumor microenvironment, in and around all of the small cell lung cancer in their body. And so we know that proportion of patients, this seems to work quite beautifully. I think unexpectedly well for a tumor that otherwise has been able to evade our best efforts at forcing the immune system to address it in the past.
So when we're talking about this type of treatment, there is a uniqueness to the administration, particularly up front. Can you talk a little bit about how this therapy is given?
Absolutely. So generally, and certainly at our institution, we are administering this medication in the inpatient setting. We typically will admit patients to the hospital one day or the evening before they're scheduled to receive the treatment. and keep them for minimum 24 hours after the first dose. And then they get a second dose a week later. The first dose is, I often refer to it in clinic as a baby dose. It's a test dose. We follow what we call step-up dosing. And so you introduce a small dose to make sure that the body doesn't overreact to it. And then a week later, you give the full dose. And the reason for this caution is because the administration of this therapy can trigger an immune response that ultimately is hopefully going to have a net positive effect on the patient's life and eradicate some or all of this tumor, but it can be overwhelming, literally, right? The immune system can get so ramped up that patients can develop fevers, they can develop very low blood pressure, they can struggle to breathe, they can even have unique neurologic syndromes where they become confused or maybe transiently lose the ability to speak. These things are scary to occur outside of a hospital, first and foremost, but they're also potentially life-threatening if not intervened upon in a timely manner. And so for now, we are administering these under only these strict circumstances. Now, there are efforts to try to move this into the outpatient setting, because I think you can all imagine that this is restrictive in our ability to deploy this medication, right? Not every oncologist has a cancer hospital adjacent to their clinic where they can easily do this. And so we want this to be available to as many people as possible. And so there are tests underway to see whether with the right precautions, perhaps a short-term monitoring in the outpatient setting with some strict precautions to tell patients to come to the emergency room at the first sign of fever, the first sign of anything abnormal, whether that proves as safe to try to make this more widely available. But I think in the short term, this inpatient administration is probably the right way to go outside of a clinical trial or other extraordinary circumstances.
Dr. Gay, so we talked about the first dose and the second dose. What about subsequent doses, and how long is someone expected to be on this type of therapy?
Yeah, so you have the first doses separated by a week. You get a third dose a week later, so that's day 1, day 8, and day 15. And then typically we dose it every 2 weeks after that. Even patients that have a reaction with those initial 1 or 2 doses, the likelihood that that reaction will recur with subsequent doses is vanishingly low. On the order of 1 or 2% of patients may have a recurrence of some of those scary inflammatory reactions. And so it becomes a very safe and easy drug to administer quite quickly if you can get through those initial 1 to 2 doses. The plan for the treatment is an indefinite one. And that's true for almost everything that we do in extensive stage small cell lung cancer. Until it stops working or becomes intolerable, we'll continue it. What we've learned in other tumors, however, is that when you engage the immune system, there may come a time where you've effectively treated the tumor and continuing to give a drug every 2 weeks is unnecessary. We're way too early to know whether that will come to pass with tarlatamab. But certainly there are precedents, say in non-small cell lung cancer, where you might stop immunotherapy after 2 years because the immune system is already done all it's ever going to do. And so we hope that this is not a situation where we're giving this every 2 weeks for 5 or 10 years, right? That we find that the patients that have these deep, durable responses don't need to constantly have their immune cells stimulated to continue to attack the tumor. But time will tell.
Time will tell on that, yeah. I just wanted to make sure that people understood it was really the first 2 doses that were the most important, because it can be terrifying, right? Particularly from the person diagnosed with a small cell lung cancer to think, wait, I have to spend the night in the hospital, and this is a good idea because, right? And as Dr. Gay said, it is precautionary for those who may respond or have that overzealous immune response to the therapy. And I think it's one of the reasons having conversations like this are so important, and one of the reasons I believe people talking to people, patients talking to patients, caregivers talking to caregivers is so important. I just spoke to someone today, a small cell lung cancer patient, extensive stage, who is on tarlatamab, and she did have an adverse reaction, and it was a delirium type of neurological reaction. But fortunately, she was in the hospital when it happened, and I'm happy to say she is still on therapy And she's like, I haven't felt this good in 3 years, right? So being able to talk to somebody who's walking the walk and can share that sort of lived experience, I think is also an incredibly important part of this, not just, us sitting here and speaking sort of at you about what all of this is, but speaking with one another. And as I think a lot of you know, GoTo has a small cell lung cancer community where we are more than happy when we can to try to make those connections. So I just wanted to do give a little bit of my input there, along with a shameless plug to some of the supportive and connectivity community type services that we can provide.
This is so true. Demystifying this drug, both for patients and even for some of the physicians out in the community, has been challenging. And I think patients demystifying it for other patients is going to be much more effective than anything that I can say, right? I mean, telling a patient that something very scary might happen to them, but they will probably be okay, I can see how that would provoke anxiety. But seeing patients that have come out the other side of that, who are now getting it as an outpatient, who are back to their normal lives, I think that's really, really the key. And I think the longer we have this drug, the more patients we'll have like that, who say, yeah, I had one of these supposedly very scary reactions with the first dose or the second dose. They knew exactly what to do about it. Somehow the antidote worked, even though I was in an ICU setting potentially. And now I come in, get what feels like a trivial infusion once every 2 weeks, and there's not really any harm at all.
Yeah.
And so I think building a community around those tarlatamab patients that are through the toughest part of it is more valuable than anything that I can tell my patients.
Yeah, or I can tell people that walk in the door. I just I think about you made a really good point about it's not just about the patient and the caregiver community banding together, having these conversations, sharing these lived experiences, but also the healthcare provider community, right? You mentioned not all healthcare providers are, have the benefit of an inpatient unit where they can house people, for the night. So how do we work to help educate healthcare providers on this type of therapy and how to effectively administer, particularly in the more rural community type settings? One of the things that, again, for those of you who are not new to GoTo, already know this, but we have a Center of Excellence community that's particularly focused on the community, cancer center, community screening centers, you name it. There's about 900 centers in the Center of Excellence network right now where we are working to try to help educate the healthcare providers in those types of settings on tarlatamab in particular, because we think it is such a valuable new tool in the toolbox from a treatment standpoint for people diagnosed with small cell lung cancer.
Yeah, I think the upside is so high with tarlatamab. The durability of some of these responses, even in the short time we've had the opportunity to utilize it in trials. I think it's almost criminal to think of a patient not having access to it because of logistics or geography. Even though it can be challenging logistically, we've been very open, at our center, and I know at many other major centers, about we'll do the first 1 or 2 or 3 doses here if that's what you're afraid of, and then if you can take over the outpatient and the patient can go back to sleeping in their bed from there. But even that is a barrier, right? Not everybody can spend 48 hours in Houston 3 weeks in a row.
Right.
And there's some people that have children or pets or what have you that they can't leave. And so making sure that everybody has tarlatamab within a drivable distance from them is really critical.
Yeah, I agree. And I know we didn't discuss this earlier, but I know it's a question that comes across our desks a lot from folks who are diagnosed with small cell lung cancer, whose cancer has metastasized to the brain, and PCI, or prophylactic cranial irradiation. So radiation to the brain, the whole brain radiation in a prophylactic sense, which historically, well, I'm not going to tell you. I'm going to let Dr. K tell you.
It's been an area that's fraught with controversy or differing opinions, and Historically for patients that had limited stage small cell lung cancer, who didn't, by definition, didn't have brain metastases at the time of their diagnosis, but successfully treated chemoradiation, the risk of failure in the brain, of eventual metastasis to the brain, was considered to be so high that you would scorch the earth, for lack of a better phrasing, and try to eradicate any microscopic disease that might be there, that might be subclinical, and prevent brain metastases from arising. And it's quite effective at doing that. It's quite effective at eradicating or eliminating the risk of brain metastases in a significant proportion of patients. But it comes at a cost. Radiating the entire brain, especially doing it prophylactically for somebody that doesn't have brain metastases, is not without controversy because there are toxicities that come with that, right? Patients can have long-term memory loss, for example. And so the field had shifted, I would say, increasingly away from prophylactic cranial radiation and more to surveillance with MRI. And now, recently, with some of the analyses from the Adriatic study, the pendulum is starting to swing back because there seems to be a signal for patients within that Adriatic study we mentioned earlier, for the patients that got immunotherapy, that maybe the patients that get the PCI are doing better. Maybe they're living longer and having a longer progression-free interval. And so I think we're gonna start seeing more PCI deployed, but it should always be a conversation. This is not, whether to start chemotherapy is barely a conversation, right? Unless the patient is focused solely on end-of-life care, you should give them chemotherapy. Whereas PCI, I think, is a much more nuanced conversation where you discuss the pros and the cons, the alternatives. And with that, I think it's important to distinguish limited stage from extensive stage, because even when I first started treating small cell lung cancer, PCI was still being offered to patients with extensive stage small cell lung cancer that didn't have brain metastases. And more recent evidence suggests that might be flawed, that those patients, while they may have less risk of brain metastasis, they may suffer disproportionately greater toxicity that outweighs those benefits, and may actually live a shorter period of time as a consequence of that radiation. And so for me, I think limited stage small cell lung cancer at least deserves a conversation about PCI with some equipoise between PCI and close surveillance, whereas extensive stage small cell lung cancer, I think, should be a conversation primarily around surveillance of the brain outside of a clinical trial.
Absolutely. Perfect way to sort of transition into clinical trials. We could have a whole living room conversation about the need to take a look at the way clinical trials are designed and run, but we're not going to do that today. I only say that because you mentioned some things that preclude people from being able to participate, transform small cell being one, quite often brain metastases are another. But how important are clinical trials?
For small cell lung cancer patients where historically our options have been so few, and clearly leaving a lot of unmet need unreached, I think clinical trials are extremely important. And we see that with drugs like tarlatamab and other T-cell engagers, with some of the antibody drug conjugates. The patients concerned that they might be being subjected to a drug that may have no chance of working for them and should just stick to the well-worn path or the well-beaten path. I understand where those anxieties may come from, but the potential upside of these drugs is huge. We're seeing response rates with clinical trial agents double what we might expect with standard of care agents. And for many of them, the only way to access those is through a clinical trial. And so, again, it's a nuanced conversation. Some patients are better candidates than others for clinical trials. Some patients will be very good fits for drugs that we have at our disposal, and that goes for non-small cell and small cell lung cancer patients. But I tell all of my small cell lung cancer patients that if they have the opportunity to enroll in a clinical trial, they should think very, very strongly about taking it.
Amen. I couldn't agree more. With that being said, I heard you say a couple of things that I think are relevant to this last question, and that is really, what are, in your opinion, some of the most important questions or conversations patients should be having with their healthcare provider?
Establishing early on what a patient's and their how they share this with their physician, what their goals of care are, right? Some patients will tell me that their only focus is their quality of life, right? That they want to They want to receive treatments that pose relatively little risk of making them sick. Other patients will say, I don't care about the risks with any of these therapies. I will do anything that might extend my life by a day or a week. And so having a shared vision for where you're going together as a team, I think is really important right from the outset. And that can evolve, right? Some patients initially want very aggressive therapy and later want less aggressive therapy. But I think if you don't have an agreement on that from the outset, things are bound to go wrong somewhere. And then I think establishing trust early on between physician and patient, that sounds very obvious, but when you work at a cancer center like I do, and you alluded to this, I think there's a lot of, there is this standard option out there, but we have a hunch or we have some preclinical evidence that this other drug might be better or might be less toxic. And if you will go along for that ride with us, that there may be some upside there. And I think if you have those shared goals of care early on and trust that the physician is, not only has your best interest in mind, I think every physician has the patient's best interest in mind, but is following along your vision for how your treatment path is going to go, what your journey would be like. I think it makes it much easier to sell innovative therapies to those patients later on, because sometimes these things on paper don't sound like great ideas, right? When you consented a patient for a study with tarlatamab or any other T-cell engagers, you have to read them a sheet that says you could die from this, right? Or at the very least, you have a very high chance of getting very sick for a brief period of time. And if a patient reads that and they're not in a relationship with their physician where they are comfortable in knowing that their patient is not being too aggressive or has goals that are not shared with them, they're going to say no to that, right? They're going to read that informed consent document and say, why would I put myself at this risk when you're telling me there's another chemotherapy that I could just get off the shelf? And so having those conversations early on, perhaps even before clinical trials come into the picture, I think is so critical.
Yeah, I know we've had those conversations in this very room before about quite often the clinical trial is the best option for you, either up front or at some point. Yeah. And another shameless plug for GoTo, but for those of you who don't know, we do have a lung match program where we will connect you with one of our lung match navigators if clinical trials are something that you are interested in, and help to try to find clinical trials that you may qualify for, that you can then go back and have these informed conversations with your physicians about. Not everyone, as we know, has the benefit of seeing Dr. Gay at MD Anderson or at one of the other, amazing comprehensive cancer centers or academic centers around this country or really around the world, which is why I think second opinions are so important. If you are feeling, lung cancer is such a complex disease. And it feels to me, not having gone to medical school, like it just gets more and more complex every day, which is the good news, right? Because they're learning more and more and more about how to specifically treat you or personalize that treatment toward you and the cancer. So most often, second opinions can be done at an MD Anderson. Treatment plans can be developed, and then you can go home and have your treatments close to your home. So we also are happy to help facilitate those types of referrals for second opinions as well. So I know I said final question, but this really is my final question. In your opinion, what is the most exciting thing happening right now or coming down the pike in small cell lung cancer?
I think the way that we're building upon the success of the T-cell engagers, so that includes moving them to earlier lines of therapy. That way you can all but guarantee that every patient will get a shot with them, but also get to the disease before it has a chance to evolve. And I think pairing the T-cell engagers with things like immunotherapy that might help to instigate a better immune response, but also with some of these antibody drug conjugates. And so small cell lung cancer is a relatively heterogeneous disease, not in the same way that non-small cell is, but with the proteins that it expresses and other things. And so hitting it hitting two legs of the table, so to speak, at the same time, one with the T-cell engager, one with the antibody drug conjugate, I think is a very promising way of moving forward as well. So you get that obliteration of the tumor that comes with the delivery of a chemotherapy where you eliminate so much of the tumor, and then hopefully the immune system just has to clean up a little mess at the end instead of expecting tarlatamab to overcome an enormous tumor burden in a later line of therapy.
Yeah, that makes perfect sense. We have our Best of ASCO after ASCO, the American Society of Clinical Oncology meeting, which is at the end of May, beginning of June every year. We normally do it in July, but we will be doing it in June this year with Dr. Josh Sabari, and hopefully we'll have some good news to report coming out of ASCO around small cell lung cancer and, of course, non-small cell. So stay tuned for that one. Dr. Gay, thank you so much for coming and spending the last hour and a little bit of change with us. I personally cannot thank you enough. I know how much it means to our lung cancer community to have you come in and talk really so beautifully and at a level that people can understand, because we know not only is it complex, it's very confusing, particularly for the lay person, to really understand what all of these things mean. So from me to you, from all of us to you, thank you, thank you. We hope you'll come back again. We really enjoyed this programming.
I thank you for giving me the opportunity, and I will happily speak about small cell lung cancer at any opportunity provided for me. So
that's wonderful. Thank you.
Tell me the time and the place.
Thank you. Thank you all. Again, to Dr. Gay, to the film crew who comes in and does this month after month, sets up, to Michelle Zay for moderating our online chat, and Amy Camp Schroeder, our other team member who's out there in North Carolina, for staying up late and helping us do this as well. And of course, our supporters, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda Oncology. Without the support from that very long list of partners, we wouldn't be able to bring you this programming and others. So a huge thank you to them as well. Until next time, enjoy, everyone. Have a great evening.
So I'll be brave if you're brave. I'll be brave, but only if